Welcome back. Season 4, episode 2 of the Me and ADHD podcast. In today's episode, I'm going to be talking about CBT, which is cognitive behavioural therapy, and its potential role with helping to manage our ADHD presentations. To help me with this, though, because I know little to nothing about CBT, I have a CBT therapist with me,
Hey.
Eliza Brabbins. How are you
Yeah.
doing?
Yeah, really well. Thank you for having me. Appreciate it.
Excellent. Did I pronounce your surname correctly, though?
Yeah, Brabbins, well done. Yeah.
Excellent. Excellent. Right. Okay. So, thank you for coming on and speaking with me today.
Mhm.
It's it's taken a while.
It has. We got there. We got there.
We have. No, it's all good. It's all good. It's the main thing is that we get to talk about it, and I get educated on this, and we
Mm,
can educate the people who are listening as well.
yeah.
Um, so you work for CAMHS, which is a
Mhm.
child and adolescent mental health service.
Yeah, that's right.
Just kids mental health service would have been easier to say.
I know, right? It would have been so much easier.
So how long have you been working for CAMHS, and what is your
Um,
role within CAMHS?
Yeah, so I'm currently a CBT therapist in CAMHS. I've worked in CAMHS in different CAMHS teams since 2013, so quite a while now. And in that time, I've done different roles. So I started off as a youth worker. So full disclosure, not always been a therapist. Did my degree in youth work back in the late 2000s, and from there started to kind of see a need for youth work in mental health services, seeing that there was young people coming in that maybe weren't ready for a therapist, or equally had therapy but weren't ready to leave the service yet, and there was just that gap. And I think youth work across, obviously ADHD, autism, various kind of presentations that we see, that there's a need for having someone to come alongside you to help you. And I think that was really my heart for it. So I kind of came in as a youth worker, doing what I could. I would do like 6 to 8 sessions around, things like low self-esteem, low mood, anxiety. But it'd be very just kind of short-term work. And then over the years, kind of did some additional training, kind of started learning more about things like CBT and other therapies like dialectical behavioural therapy, things like that. And kind of decided at one point in the late, when was it? 2022, I kind of was like, right, I need to now take this further. I want to help more people. I want to do more. And so that kind of led me to then training to become a CBT therapist. So qualified at the end of 2023, and since then have been working as a CBT therapist in the trust that I'm in now. I'm from Birmingham, so I'm in the lovely world of Birmingham, and yeah, just my role kind of consists of supporting people with, it's another acronym, we love our acronyms in the NHS, but people with ADOP. So if you think about anxiety, depression, OCD and PTSD, it's those kind of four main presentations. Obviously with that anxiety you have things like generalized anxiety, phobias, social anxiety, that kind of stuff. So you think about all the different kinds of anxiety disorders that we might see, but I use cognitive behavioural therapy as a way to help support people. I think when I say I'm a CBT therapist, I think people have had different experiences of CBT, because CBT can be not washed down, but it can be reduced down to a couple of sessions. Whereas my role is I'm a high intensity CBT therapist, and the difference there is I'm trained to a very high level in that therapy, and therefore can provide, you know, 12, 20 plus sessions on what has brought them into the service.
Okay. So there's different levels of, I guess, qualifications or whatever of
Mm.
CBT.
Yeah, that's right.
Okay.
Yeah. So you can range from, it's certainly in children's services, we have what's called low intensity CBT. That is that 6 to 8 session model. It's CBT informed and it carries the CBT principles, but it doesn't treat the more complex to severe mental health disorders that we would see kind of in a CAMHS service, really. So you might start there, and then you end up coming into CAMHS, and then you come and work with me, and we try and take that problem and see if we can kind of improve it further than what was done in the original work.
Okay. So when it comes to, I know obviously there's lots going on within CAMS, but
Mm.
with regarding sort of the ADHD,
Mm.
where are you? Are you involved with that process, that assessment? Is there extra training needed or not needed, or is
Yeah.
that something that you're not involved with at all?
In the CAMHS teams that I've worked in, I can't, because CAMHS is it's a broad term for all children mental health services across the UK. So they're all different. They should apply very similar principles, but they are all kind of set up slightly different, which means that you might get some CAMHS services that do diagnose and treat ADHD, and then you get others that don't. So in my current trust, we have a separate team. So I have nothing to do with the assessment of ADHD, but I absolutely support in terms of treating young people who have ADHD and a mental health disorder. So it's kind of that we're here to support anybody with any issue, regardless of neurodivergency, things like that.
Okay, that's interesting because within our world, I guess, with
Mm.
neurodivergence, when it comes to CAMS, it's always about either autism or ADHD. So it's
Mm.
very
Mm.
easy for us to slip into this. That's all you do kind
Right.
of thing, kind of
Yeah.
my guess state of mind really. But you do a lot more than that, and
Mm.
it's something that we need to obviously understand that you are there to do so many different things, and ADHD and autism
Mm.
are just a small part of it, I guess.
Yeah, I think something that I'll happily get on my soapbox about is the need for more specialised services with neurodivergent people. I really wish there was a service that was specifically catered to not just assess, not just treat, but really like a holistic package of care for both people who are autistic, people who have ADHD, combination of both. And it doesn't, as far as I'm aware, that it doesn't exist. There isn't that kind of setup, and so I think what happens is then CAMS is that space that we get everybody in anything. We are, even though perhaps some people might see CAMS, and I understand why, as kind of this the threshold's really high. It takes a lot to get into CAMS, but the reality is we will work with everybody and anybody when they have a severe mental health disorder. We're not there going, oh, you're autistic, therefore we can't treat you. Actually, if you have a severe mental health condition, we're gonna offer you that support, or at least that's what they should be doing. And I'd say the majority of my caseload are neurodivergent. So it's incredibly common now. I'd say actually, yeah, I don't have very many neurotypical young people on my caseload for that reason.
Okay. So, all right then. So what do you do within CAMS then when it comes to ADHD? When do they come to see you? What's
So,
the process, I guess, or what do you do?
so I've worked with young people that are either waiting diagnosis, have a diagnosis of ADHD, and so I've kind of seen both sides of that experience where they've come in, and the reality is they can come in at any point, because we're focused here on the mental health need. Whether you
Yeah,
have ADHD or not is not irrelevant, because it's incredibly relevant, but that's not going to be the barrier. So if you've got, young people with ADHD, may struggle with self-esteem, they may struggle with anxiety around going to school. So that, whether they have the diagnosis or they're awaiting diagnosis, we would get involved at whatever point there's a mental health concern that requires that input, if that makes sense.
yeah. Okay. With that, I know you mentioned like sort of the anxiety and with school and things like that.
Hmm.
I know this wasn't one of the questions, but and hopefully
That's
this is a bit
okay. That's okay.
when it comes to being referred for that.
Mm.
Okay, for the anxiety aspect, is the waiting lists generally still horrific, or are they a lot? Mm,
Yeah, yeah. I think waiting lists. Certainly on my TikTok, it's one of the questions I get the most about, like, why are the waiting list so bad, and I think there's a couple of things with that. One, I do think it's a bit of a postcode lottery. It shouldn't be that way, but the reality is I've worked in CAMHS services that have had really short waiting lists. In comparison to others, for example, our current psychology wait list is about a year to a year and a half. But I've heard of services that have 3 to 4 year wait lists, which is absolutely atrocious. And then equally, I've worked in CAMHS services that will see you within 6 months of referral. So it does depend, and I think some of that, again, without trying to get in trouble or get on the soapbox too much, it's about funding. You know, children's services in mental health services do not get as much funding as they should, and this is the reality. And also not having specialised services. You know, if you don't have a specialised service for neurodivergent young people, then or people that have personality disorders, or people that have other mental health difficulties, then there's a feeling of they all get swamped into the same place, and then the waiting lists start to grow. And if you don't have people trained to work with these conditions, especially comorbid conditions, you know, when someone might have ADHD and autism and depression and trauma, you know, the services are not equipped. There's just not enough funding in place.
That's an interesting way to look at it, because we kind of feel that, I guess, when we go to see someone, the expectation is they'll do everything. But in reality, you would have to be quite, I guess, for one person to be able to do as a speciality all of those things, be it assess and diagnose for ADHD, autism, trauma, anxiety,
Oh, yeah.
Tourette's,
Mm.
all
All
these
singing, all
things. Oh
dancing.
yeah,
Yeah, yeah.
you would be in education until sort of mid 50s, 60s before you're
Sure.
qualified to do all of that.
Yeah,
And be specialized in it.
yeah, yeah.
So it's, I guess, looking at it, we're going to not everyone, but a lot of people, we go to them where we need to go to I don't know, be it a pediatrician or a surgeon or something like that in a hospital, specialized in a certain area, but we end up going to a GP who
Mm.
knows a little of everything, but
Mm.
not
Totally.
specialized in a certain area.
Yeah.
I don't know if that's a good analogy or not,
No,
but
yeah, I know. I think it is. I think it is, and that's the thing, you know. That, and the reality is, like you say, you'd be in training well into your 50s. You know, if you try to become an expert in all the things. And this is where, you know, even when people ask me, like, what's the difference between you and a psychologist? So I would say a psychologist is someone who trains in multiple modalities of therapy. So modality being CBT or DBT, or motivational interviewing, compassion focused therapy, the list goes on. They train to a good level, but they train in lots of different modalities. And that is a fantastic thing, because you've got someone with lots of complex needs from different walks of their life and what they've been through, and again, factoring in neurodivergency and other things, you're going to want someone who potentially can steer you with lots of different therapies. But just as much as there's a need for that, there's also going to be a need for therapists that are trained in one, but trained highly in one. So, and this is where I think, CBT sometimes can be seen as a bit of a Marmite therapy, because it either works or it doesn't, and that's okay, because it shouldn't be a one size fits all. I think sadly sometimes, because CBT is an evidence-based therapy, it's the most research therapy, I think the tendency is to just go, oh, chuck CBT at that, and that will definitely work. And you just think, well, no, it's about the individual. And I think especially when we're thinking about being neurodivergent, ADHD, autism, I've had people on my TikTok say things like, oh, well, CBT doesn't work for ADHD, people with ADHD, or CBT doesn't work with autism. And I think, well, actually a lot of that is down to how the therapist and how they cater and tailor the therapy to the individual. Sometimes it won't work because it just doesn't work, but equally, how good is your therapist? Are they, when I've
yeah,
got, I'm working, I've worked with several young people with ADHD. You best believe in my therapy sessions with them, we're getting up and we're walking around the room, we're kicking a ball about, we come and do 5 minutes of work, and then we move around, we take movement breaks, we find different ways to still do the same work, but just in a different way. And I think that's, for me, is more about CBT can work with people who are neurodivergent, but a lot of it will come down to the therapist who's delivering that. Can they adapt it? Have they got the training? And have they learned how to, just through experience, adapt the protocols that we use for people who are neurodivergent.
Yeah, I think that matters a lot. I know my I go to a psychotherapist,
Mm.
and she's ADHD as well,
Mm.
and I did that on purpose, because
Yeah,
what I was going for, I didn't want to have to explain everything else as well
sure.
before I get to the main issues I wanted to talk about. You know what I mean? I
Mm.
needed to be
Mm.
accepted straight away.
Yeah,
Um,
absolutely.
so it makes a big difference. And
Mm.
like I say, not all therapists are the same.
No,
You know?
not all therapy, and psychotherapy again is a brilliant example of, for some people, psychotherapy is just the best. And I love psychotherapy. I think it's an incredible form of therapy, but that won't fit everybody either, because it's so big in terms of where you can go with psychotherapy. Whereas CBT inherently is quite specific, quite targeted. And again, for some people who are neurodivergent, that's a really comforting thing. My patients see me at the same time every week in the same space, and they know that our order of therapy will always be, how are you? Let's set our to-do list. What are we working on today? It's structured, and for some people it's like, oh god, no, don't give me structure. And then for others it's like, no, I need that, I crave that. So again, it's the adaptations that the therapist can put into the room to help with that, I think,
Yeah.
is so important.
Okay then. So as a therapist then, you're doing your CBT. How
Mhm.
how do you differentiate, or how can a therapist differentiate between the overlapping symptoms of ADHD and autism and trauma
Mm.
and all the rest? Because there's a lot that are very similar.
Yeah,
How
yeah.
do you go about how do you go about going, okay, this is that,
Mm,
this is that?
yeah. Oh, absolutely. I think some of it is about kind of understanding their developmental history. So, when we're looking at working with young people, when working with anyone, you'll always hear the word holistic, because you should be looking at every part of them, not just honing in on either the mental health concern or that they have ADHD. Look at the whole picture. What have they been through? The overlap between developmental trauma and autism and ADHD. That they can look quite similar, and you're only going to know if you take the time to get to know your patient. If you take the time to take that developmental history, what was their life like in their earlier years? What experiences shaped them into the person they are today? What was their relationship like with their caregivers, who was close to them? What did school teach them? CBT operates on this idea that everyone holds core beliefs about themselves, others, and the world, and so we'd be looking for that, and that helps then when you're trying to recognize, okay, what am I seeing here? Am I seeing symptoms of ADHD, and actually the anxiety is being more triggered by that, or is it more being triggered by, because you were bullied in primary school and that's led now to anxiety in school because you're fearful it will happen again? And I think a lot of that is about really getting to know your patient, getting to know the person in front of you, and not jumping to a conclusion. I mean, I know it's not ADHD, but to give an example, patients with autism, and I've got quite a few patients with autism who also have a diagnosis of OCD. They look and feel very similar, and so I get the Venn diagram out, do the two circles, and kind of go, all right, well, let's think that, and I'll do it with them. I'll get and again, for people who are neurodivergent, certainly people with ADHD, getting out that piece of paper and drawing it out so it becomes far more easier to take in, rather than just sitting there and talking.
Yeah.
And helping them in that moment get a real clear sense of, oh, I am who I am because of these things. We call it formulation, but it's just a fancy way of saying, how did you get here? What part? So I think, yeah, when you're, yeah, obviously, you're also looking at things like, we've got, the DSM-5 and the ICD-11. These are the diagnostic manuals that we use. So I could refer back to them and go, yes, I'm seeing signs of, object permanence. Oh, okay, that feels like, come here. But again, it would be, it wouldn't be wise to just suddenly assume that everything, someone has object permanence, so it must be ADHD that's causing that. Well, what if it's trauma? What if they're disassociating? What if there's something else that could cause that instead? Time blindness. What if it's because, I mean, I have epic time blindness, but jumping to, oh, it must be this, I think, and to flip it, we know that on social media now you've got a lot of people self-diagnosing themselves with, oh, I have ADHD because I can't sit still. And you think, well, hold on, there might be other reasons for that. So it works both ways, we can't be jumping in. So that's my very long way of answering that question.
I don't even know what question I asked you now. But,
No, no, yeah, yeah, exactly, yeah.
Okay, no, that's because there's a lot behind it all. It's
Mm,
not like you say, it's not as easy as just I forget things that I must be ADHD. And
yeah, right.
one of my pet hates, I guess, on social media is a lot of posts like that. Some are
Mm,
funny, some are hilarious, like which is
yeah, yeah,
fine.
yeah, yeah, yeah.
But when it comes to like the argument of really being taken seriously with having ADHD, um,
Yeah.
it's hard to look at some of the posts that kind of are very specific. If you do this,
Mm.
you have
You
ADHD.
must be,
Yeah,
yeah, yeah.
which is it's a little
It's
bit
so
annoying.
unhelpful.
Yeah,
It's
I, th-
so unhelpful.
I like to think it all comes from a good place,
Sure.
but regarding what we're trying to achieve and the recognition and understanding what we're trying to get and support,
Mm,
it doesn't help us much,
no.
um, because there's a lot more to it. You
Yeah.
know.
And you want to, in therapy, you're trying to help someone understand themselves completely. And, I was speaking to a patient the other day about, when they got their diagnosis of ADHD, no one really took the time to sit and think with them about what that would mean for them. And they're a girl as well. So again, as we know, how ADHD presents in girls is very different to boys. And so when she got that diagnosis, it was met with, oh, am I just going to be hyperactive and I'm not going to be able to sit still and clap? Those stereotypes come out. And so I think, yeah, helping people kind of really get that understanding of what my ADHD looks like, what my autism looks like, and how I then understand that in the context of therapy when I have a mental health condition as well, and the overlaps, like it's important to recognize. And I do think a lot of our work is about helping people find their identity in
Yeah.
in themselves and in their, not, they're not just a diagnosis is so helpful, but I think the problem can be when people make that their only part of their identity. We need to find ways to absolutely be who you are in that, but equally hold in context everything, as well. Things like rejection sensitivity for people with ADHD, that comes absolutely from the ADHD, but it can also come from if you've had some nasty traumas and some, depending on your relationship with your caregivers and things like that, that also stems from there. If you're a people pleaser, because you're afraid of rejection. So again, it's taking that time to really sit and think about, okay, how did you get to where you are? Let's hold in mind the ADHD, let's hold in mind what else has happened, and take it all together rather than separate it out.
Yeah. It's I find that the people, a lot of, well, pretty much everyone that I speak to, are late diagnosed.
Mm,
Um, and I do find that everyone's singing the same kind of song regarding depression, anxiety, and all, and the traumas they've gone
mm,
through their education or, careers and things like that. It's all very, very similar.
mm,
Um, I think the only difference, I guess, that I see is when you've got other I don't want to say other neurodivergent conditions in there as well,
mm,
such as um, autism,
mm,
as opposed to, as far as I'm aware, I'm depression, anxiety, ADHD. I'm not
mm,
autistic, but then you
mm,
you've got the autistic aspect of it is with other people.
mm.
Then you've got different kind of parts of the story as well that
Sure.
I'm not going to relate to. Um, but it's interesting talking to the amount of people I've talked to, how I guess similar most aspects are, but then how it branches off into very different sort of areas that I for one can't relate to,
Yeah,
because that's not my story. You know what I
yeah,
mean?
absolutely.
And it's
Well, I think. think it's, you know, the phrase, you know, you meet one person with autism, you meet one person with ADHD, you have met one person with autism,
Yeah.
one person with ADHD. It really isn't as, you know, I think when they developed the autism spectrum wheel to help people understand that there are, yes, there are similarities, but ultimately there are levels within those similarities that will massively differ. You know, from one of my best friends has ADHD, and what his ADHD looks like is completely different to some of the patients that I work with, and that, again, that's okay. But it's understanding, yep, there are similar themes, there are things that I have to watch out for. But equally, no, because everyone's life experiences, you know, will influence the way that you see the world. You know, like in personal construct psychology, it talks about this idea that, you know, everyone goes through the same. You know, if four people are in a plane crash, one comes out and goes, oh my gosh, I almost died, now I need to live my life to the fullest, and, you know, go out and do all the things. And then another person comes out and goes, oh my gosh, I'm never flying on a plane again, and they've developed a plane phobia. And one person comes out going, that's it, I hate my life, what was the point in that, God hates me, you know. So, and then one person comes out going, I'm totally fine and I'll just carry on life as normal. And
Yeah.
and that is because our perspective influences our reality, influences, and our perspective comes from our life to date. And again, that our experiences will influence how our ADHD manifests, how our autism manifests. You know, that these things will determine, again, when we think about attachment and autism, for example, you know, the strong need for routine comes absolutely as part of, potentially, you know, again, not everybody with autism is like this, but, you know, a need for routine can be seen as being autistic, but it can also be understood as someone who has gone through a difficult attachment, an insecure attachment with their caregiver, and so has developed routine as a way to feel safe. And they feel very similar, and yet there are small differences that help us go, okay, we're seeing more
Yeah.
this, we're seeing more that, or both, because sometimes it's both.
No, that's true. I mean, I hear all the time about, you know, we want to be, you know, we don't like boring. We don't. We want things to be different all the time. And no,
Mm,
actually, I need routine. I know we need routine, but I want routine because I know what happens when I don't have the routine, and my routine is
yeah,
about remembering things basically. So I'll do things in
totally.
certain orders.
Yeah.
Um, and I don't freak out or anything like that. I have a
Mm,
meltdown if it doesn't happen. But if like I'll cook a certain meal in a certain way,
mm,
certain the pans and the
mm,
utensils are in certain places and all that. It looks
mm,
very, I say this very loosely, very OCD how I do it. It's not OCD,
sure. No,
but
no.
the reason why I do it is because if I do it a different way, I come out because it's like automatic mode. I'm just
Mm,
going through it and it's great. But if
yeah.
I then have to kick in with my um, you know, and I have to really think about what I'm doing. My executive function is working now overtime.
Mm, mm,
I'm going to start forgetting things. I am
yeah.
forgetting to, oh, I forgot to put that in. Oh, I've left that in there for
Mm,
too long. It's Some just come and talk to me for like 5 minutes, and now,
the whole
yeah,
thing is
yeah.
off. Yeah.
So
Yeah.
that's what happens when I don't, you know, when I come out of my sort of
Mm.
routines, and that's why I need my routines all the time.
Yeah, yeah, no, absolutely, and you're not, you know, you're definitely not alone in that. I think, you know, certainly for ADHD, the fear of forgetting is so prominent, and, you know, this is where, again, a good therapist will, and certainly in the world of CBT, you'd be holding that in mind. You know, when, like you said, you're like, this is an OCD, and of course it's not OCD, because actually, again, it's your need for a routine, if we're thinking about it in CBT, that need for routine and order is a behavior, but that behavior is coming from a thought, you know, cognitive behavioral therapy, the way we think, the way we behave. So that behavior is being driven by a thought. Now, if it was OCD, it would be, I have to do things in a certain order, otherwise my family are going to die in a fire, or, you know, I'm going to cause a natural disaster. But actually, for the ADHD brain, it's, well, the thought is, if I don't do this in this certain way, I am going to forget something. And then, if you really want to get deep in therapy for therapy about it, it's how that then makes you feel about yourself. I'm inadequate, I've done something wrong. And so I would say for CBT, it might be that we don't necessarily try to always change that behavior, because if that behavior is serving a function and it's actually improving your functioning, we wouldn't necessarily want to take that away. What I'd be wanting to do is go into the thought and go a bit deeper in the core belief of like, well, if you do forget, if something does happen, you know, what does that say about you, and how does that leave you feeling about yourself? And you know, I know from my experiences working with people with ADHD that critical voice when you make mistakes, which we all do, but certainly I think because, like you said, the executive functioning is going on overdrive. Those are the things that I think CBT could unpack a bit more, and that thought challenging, and not necessarily sitting constantly in that place of, if I do forget, or if I misplace, or if I don't turn up on time, then suddenly I'm the worst person in the world and I need to go and die in a ditch, you know, and not going to that extreme. So yeah, that just a little side thought there.
That's good.
Try not to give you a therapy session here.
Oh no, I'm okay with that.
Okay, cool.
Yeah, I mean, there's so much that we don't know and we don't understand, and it's kind of sort of we touched on the self-diagnosis and social media stuff before, but we do have to be aware that there's a lot more to things.
Sure.
I mean, I didn't know. I mean, I said for a while that when I was, like I think a lot of people, I was very OCD when I was younger. Um, and I can see why. I know what I did and what I had to do and how I felt and stuff like that. But that's kind of like the surface of OCD that people know about. They don't know the rest of it. And when I
Yeah.
found out about the rest of it, the thoughts, intrusive thoughts and things like that, I don't
The
have any,
urges, the
none of that.
compulsion.
No,
Yeah.
I do this because I just really don't like it.
Yeah.
That's it. You
Yeah.
know, I'm
Yeah.
tidy because I really can't stand a mess on that. And
Yeah.
I've got to sort out the curtains properly because it's just driving me nuts.
Well, and
Nothing.
it leaves you feeling uncomfortable.
Yeah.
And I think that is the thing. Like, I'm writing a paper at the moment to do with the overlaps of autism and OCD. And I think this is the thing that I've seen, and definitely it also applies to ADHD, is that what may on the surface appear as OCD, because I need to have things done in a certain way. It's actually, it's being neurodivergent. And my current go-to, I might change my mind on this based on when I finish the paper, but as it stands, my go-to is about the feeling it creates.
Yeah.
If you go, I have to do things in a certain way because if I don't, it makes me feel incredibly uncomfortable and I can't relax and I can't settle. That gives me more of an indication that you're neurospicy. And if you are actually telling me, no, I have to do this because if I don't, again, it's this catastrophizing and magical thinking of, I believe something bad's going to happen to my loved one. God is going to smite me as I walk down the road. If I don't do this, I'm going to become a paedophile. These are the things that are OCD. And again, you can have both. You can absolutely have someone who is neurodivergent with OCD, but I think I was talking about this with a patient the other day, having empathy for yourself and recognizing, because I think when people come into therapy, it's like, you've got to get all of this gone because this is all bad, and actually going, I need to help pick apart and go, actually this stuff is because this is the way your brain is, and you wanting to feel comfortable is not a bad thing. That feels more like something we could probably chat, and helping them piece out that. And I think
Yeah.
my go-to question will always be, well, what's your impact to functioning? Someone comes to me and says, oh, I have to switch the light switch off 3 times before I leave a room. Okay. And then do you get on with your day? Yeah, I do. Okay. And if you don't do that, oh, it just makes me feel a bit uncomfortable. Okay, well then carry on with the light switch. But if it becomes, I now cannot leave my bedroom because I'm not getting the light switch right, that's when I'm like, oh, okay, we have an impact to your daily functioning now. You're not able to do the things you want to do in life. And I think, yeah, again, then when meeting someone who comes to therapy going, I'm neurodivergent, but I've also got these things, it's going, okay, calm. Let's figure out actually what is some of the stuff we want to keep, because it'd be ridiculous of us to think we can fix or cure, as if, for the sake of those who are listening, I'm doing quotations, I'm not saying this to you, but I think there's nothing necessarily to fix or cure about you. It's just helping you understand yourself and the way your brain works better, and from that, challenging the thoughts that don't need to be there, challenging the behaviors that don't need to be there, but that, especially when it comes to like object permanence, forgetfulness, things like that. Like you have systems in place to help you. I don't think we should be trying to get rid of all those systems because it will impact your functioning.
No, no, absolutely. I mean,
Mm,
I've got so many things that I've put in place. Since I got diagnosed, it's only a couple of years ago. Um, I've only put a few things in place for myself
mm,
that I hadn't before. But the main things that I've put in because of life, not because of
sure.
anything to do with ADHD in my
Mm,
mind. It's
mm,
because I am forgetful, and I get in trouble for forgetting all the time. So I've got to sort this out, and
yeah,
so my life, my working memory is on Google Calendar.
totally.
I have
Yeah.
alarms for the last probably 15 years, 20 years maybe. I've had
Mm,
alarms going off, reminders going off throughout the day, telling me what to do, when to do it,
mm, mm.
all the time. And if I don't put it on there, then
It's not
it's not
happening.
happening.
Yeah.
No,
Yeah.
um, but that's just because of life, nothing to do with ADHD.
Well, this is it, and I know I said to you when we were back and forth, all my colleagues are joking that I might have ADHD because I have a lot of symptoms of it, but I think maybe I do, but equally what I recognise, and like goes back to what we were saying earlier, is that well, I'm a mum of two. I have a 6-year-old who's autistic, non-verbal, and has a learning disability, and I have a 4-year-old who's a crazy 4-year-old, and so my brain, my working brain, is not what it was before when I had, when I was free. And so now I've developed a lot of systems, and you could absolutely look at my life and go, well, Eliza, you've created those systems because you're ADHD, maybe. Or it could be you have created those systems because you are working, full time, and you're a mum and you have someone who has a lot of additional needs. And so, yeah, because I'm exactly like you. If I don't have it as a reminder, it will not get done. And you know this because of us back and forth chat. If I don't set reminders, I don't do it. And so, yeah, there's that. And it goes back to your point around social media, is having the discernment to go, okay, before I jump into it's definitely this or it's definitely that, can we look at the whole picture here to go, well, there might be some other things that could be explaining what's going on here. Can always be both, but there could always be other things that might help us understand ourselves a bit better here.
Yeah, yeah. I mean, I did what I think guess a lot of people do. They'll do the those pre-assessment things that you can get online and all that.
Yeah.
And I did mine. They all scored really high. I went for autistic assessment first of all with a different company, and
Mm.
they said no, but they see ADHD. Um, and then I got my ADHD, and it's like, yes. So
That's me.
I'm an attentive type,
Mm.
predominantly, and yeah, I think that there's traits there that they saw from autism, but that does not mean I'm autistic.
No.
Um, you know. However, I think the way I look at it is I'm ADHD. I'm on medication. This is what medications help me with.
Mm.
This is what I struggle with, and there you go. I don't
Yeah.
need to know anything else really, because this is my
Sure.
struggles. This is what I'm trying to
Mm.
do.
Mm.
Um, but it's very easy to go, oh yeah, look, I've done that form and it says I'm autistic, so I must be autistic. And I did
Yeah.
that. I thought, yeah,
Mm.
I look,
Yeah, probably.
and they
Yeah.
said no. I'm like, okay.
Mm.
Um,
But, I mean, to
go
throw
on.
a spanner in the works, so they could sometimes just be wrong.
Well,
And
yeah,
that's because we see that. I think we're getting, as a society, we're getting better at identifying and spotting signs earlier, and getting, like you said, so many adults get late diagnosis of ADHD, or we're seeing people who were once diagnosed with bipolar actually having that diagnosis removed and it actually being autism. That I think that there's an understanding, but I'd still say we've still got a way to go. Certainly working in children's services, I'm meeting 14-year-old girls specifically who have not been clocked for ADHD, not been clocked for autism, and then they come to us because they're having a mental health crisis. When actually what's happening is years of masking and years of not being spotted have got them to a breaking point at 14 when hormones are sky high, pressures of school increase, and suddenly all the rituals and routines of the playground in junior school no longer apply. Socializing is a lot harder, and then suddenly we see it coming out. So I think we're getting there, but we've still got a way to go.
yeah, yeah. Yeah, I very much like that myself. None the wiser.
Mm,
I knew I couldn't
mm,
concentrate, but that's about it. Um,
yeah.
I didn't know anything really
Mm,
until I we had a son, and finding out, well, before we found out that he was autistic ADHD with a demand avoidance profile.
mm,
Um, and all of a sudden I'm getting triggered by so many things, and
mm,
I've got um, sensory issues that I
mm,
never knew I had. But looking back on my
yeah,
life, I've kind of molded my life into quietness on my
sure.
own, and
Mm,
all of a sudden it's all this noise and things are going on that I've just
mm,
and
yeah,
and
yeah.
that's what pushed me down the line to get assessed, because I'm like, I don't know what's
Mm,
going on here. This I can't handle this
yeah,
at all.
yeah.
So things change. Your life, your surroundings can
Mm,
exacerbate or can alleviate,
mm,
and it can be, yeah, it can be an eye opener when it hits you in the face. So
totally. And I think your story probably resonates with a lot of people actually, because I think, more and more now, certainly in CAMHS, as we see patients get diagnosed with ADHD and autism, you just look at the parents and they start to go, ah, is that, oh, is that, I didn't really, like, I absolutely, and I'd agree with myself. I always knew I got quite a high sensory profile, like I'm quite sensory avoidant, but didn't quite clock it fully until having my own child with autism, and then being like, oh, okay. So there was a reason as a child I never wanted to wear anything that had certain things, sensory feelings to it. And how I think socks are feet prisons, and I hate wearing socks. And as soon as it gets warm enough, I wear Birkenstocks until it's just when my feet are freezing, and then I'll go back to wearing the same pair of shoes. And and so again, I think it's children definitely bringing awareness to your
yeah,
own systems, and your own way of coping and your own way of working and figuring out the world. And again, I think in therapy, it's never always about trying to dismantle all of those. Like, I think sometimes there's a fear, certainly in CBT, that you're going to come in and we're going to just try and change everything that you do, and that's wrong, that's wrong, that's wrong, don't do that. Actually, in reality, that a good CBT therapist should not do that. They should be working collaboratively with you
yeah,
to say, well, what are your hopes? What are your goals? What do you want to work on? I've got patients, you know, treat phobias. A patient with a metaphobia, fear of vomiting, and she is also autistic and demand avoidant. And me asking her what her goals were triggered a demand avoidance in that in itself. But again, we work through that, because again, you figure out ways to adapt and reframe the question in a way that's less demanding. And one of her goals was to be able to drink a milkshake, because when you have a metaphobia, the fear of drinking something thick can and it's a sensory nightmare as well if you're autistic. But she really likes milkshakes. So one of her goals for therapy was to be able to drink a milkshake. And she now can drink a milkshake. And to someone else, that might be like, oh, that's your goal for therapy. But for her, that
that's
was something
huge.
that there was massive. Yeah. Like, she wanted to be able to go out with her partner and go to, McDonald's, whatever, and drink a milkshake and not make it this massive, big mental health crisis moment where she thought she was going to be sick. And so, yeah, I think this is where a good therapist of any modality, not just CBT, should be really thinking with you, well, what do you want to get out of this? It shouldn't just be what I decide you need. Yeah.
So when it comes to the CBT, then
Mm.
does it help any of the core presentations of ADHD, or is it kind of everything else that life has given you because of the core presentations of
Oh,
ADHD?
how do you mean? Give me an example.
Well, is it? I mean, well, okay. I am. This is a guess because I
Mm,
don't know. I'm
mm,
guessing going to CBT or any therapy, to be honest with you, is not going
mm,
to help me concentrate on reading. Okay,
mm, mhm.
the medication helped me quite well with that,
Sure. Yeah, yeah, yeah.
but I can't see anything else helping me to be able to
No.
read and remember what I've read.
Mm,
Um, but then the the lack of self-esteem and the lack of self-worth because I can't read
Yeah.
and remember.
Hmm.
I'm guessing the CBT is better for that as opposed.
Yeah, I'd say so. I think, yeah, there's definitely, I'd say if someone came to me going, I want therapy because I can't read and concentrate, I think it'd be one of those of, yeah, I'd be wondering what was causing the lack of content. Like, it's the thing behind the thing, like what's causing that. And actually, if it turns out that it's ADHD, I think you're getting a great example there, because actually medication and therapy, in my opinion, will always be the perfect combination. Like, not that everyone needs medication, but I do think if you are a person, certainly with ADHD, who needs medication, having medication and therapy is going to work so much better, because what the medication will do is help your concentration. But as you said, what it won't do is necessarily work on the core beliefs you've got about yourself when you can't read. And so I think, and part of that as well, like solution focused therapy, as the name kind of suggests, is solution focused. It's about helping people come up with their own solutions to problems. And so certainly, and this is why I'm saying, well, no, it probably could help a bit, because actually I think if my patient said this was something I'm struggling with, I'd say, okay, well, let's think about creating a SMART goal, specific, measurable, achievable, yeah, that helps you read more. If this is something you really care about, should we think about a way that you could create that within your systems, within what works for you? Can we think of a way that you could increase your reading? And it might be that you just increase your reading, you do 5 minutes a day. And then if that feels too hard, you do 3 minutes. You know what I mean? So you could do some more practical work, because again, that's a behavioural approach.
Yeah.
What behaviours can we change? So yeah, I think if you're going into therapy purely because you got ADHD and you like, I've just got ADHD and I want you to help me manage my ADHD, that might be slightly challenging, certainly in a CAMHS perspective, because I think it's really about mental health. I think if you're paying for private therapy, you can go in with whatever you want, because you're paying for it. But certainly for CAMHS, we'd be looking at, and how is that impacting your mental health? Will always be the question that follows. Like, I have
Yeah.
ADHD, okay, and how is that impacting your mental health? And that's the thing we'd want to look at.
Okay. Now, CBT's had, for what I've sort of read, has had bad press, sort of in the past, maybe now,
Mhm,
regarding, I guess, neurodivergent conditions and
mhm,
mainly ADHD. To be honest with you,
mhm.
that's probably what that's what I've been focusing on. Um, why do you think that is? And I know you you can't believe everything that you hear in the news and or on
Mm.
social media and stuff like that, and it's things taken out of
Yeah. Yeah,
certain
no, but
proportion and all that.
I don't fully disagree. I do love it, CBT. Wouldn't do it if I didn't love it. But I also recognise its limitations, and I think, like I said, like I think bad CBT can be done by bad therapists, and sometimes people shoehorning someone into a therapy that just ultimately was never right for them to begin with. And I think often that's the thing I come across more, is people are kind of being pushed into having this therapy, and if their goals aren't aligning with the kind of style of working that CBT is, it's inevitably not going to work. Or what does all the research say, like 70% ish, the number, I feel like the number changes, but it's around like 70% of what makes therapy successful. It's not the modality, it's not how smart the therapist is, and it's not even to an extent about how motivation from the patient is important, but it's not that. 70% is about the therapeutic relationship. It's about how they connect to their therapist. If you haven't got that right, the rest falls apart. If a patient isn't motivated, and if they feel like they can't get on with their therapist and their therapist doesn't understand them, you can be the best therapist in the world with all the knowledge, but it's not going to do anything. Or it might shift a little bit, but not a lot. And so I do often wonder, when people go, CBT was crap and it didn't work for me, I'm really always curious to go, what was your therapist like? How was that relationship? Like, did you feel like you could talk to them? Did you feel like you had that connection? Was it collaborative? Did you feel like you could say, that's not working for me? You're talking at me for 10 minutes and I'm getting bored and I can't concentrate. Can we change things? Did you feel like you could have that conversation? And if you didn't, well, I think therapy was doomed from
Yeah.
the get go. But I think as well, CBT, there are different schools of thought. So certainly in the high intensity CBT world. I've met CBT therapists who are very rigid, ironically, in their we're here to treat this thing. You come in with this one problem. We have protocols that basically for each mental health presentation we have a set protocol we have to follow. And I've met some who are very, very rigid in that. We follow the protocol, irrelevant. And traditional CBT, it relies heavily on things like worksheets, long discussions, a high working memory load, and homework completion. These things are not always going to be great for people who are neurodivergent. And so this is what I was saying earlier about the adaptations. And I think this is where it will fall down. If someone's expecting someone with ADHD to sit down for 60 minutes and do some quite high intense CBT with no adaptations, it's not going to work. Just full stop. So I think, you might hear therapists, we talk about the cognitive approach and the behavioural approach, and that's just a fancy way of saying thinking, the doing. I would argue people with ADHD need more of a behavioural approach. We need to be doing some more things, not just necessarily talking for an hour. So whether that's, if they have a phobia, let's use something easier. If they have social anxiety, I could sit with them in the therapy room for an hour each week and talk about how they can cognitively challenge their social anxiety. But what I'd much rather do with someone with ADHD is go for a walk in the park with them and help them start to observe what people are doing. Like I had a patient with ADHD who had social anxiety, and we went down to the corner shop, and this was an experiment that we'd kind of set up because I wanted to help challenge her beliefs that people are judging her. And so I took out my phone and I played a really obnoxious ringtone and I put it at full volume, and I walked away from her and played it and got her to observe me in the moment walking around with this really loud ringtone to see what other people, how they reacted to me. That I could have explained that in a therapy session sitting down in a nice warm clinic, but that wasn't going to be the thing that was going to land. Her attention span could not cope with that, but she absolutely took away the point we were kind of getting to in that experiment. We did other experiments where we went for a walk around the park, and and then got her to do as her homework tasks, because homework tasks are an important part of CBT. But her homework tasks were all behavioural. Right, I want you to go into town and I want you to cough 3 times and see who turns around, and what do they do when they turn around, and just send me an audio voice note rather than, because again, traditional CBT journaling, well, not everyone wants to journal. So yeah, it's being creative, it's being playful, using, like I said earlier, visual aids, writing stuff down, allowing inconsistency. These are the things that will make CBT work, but ultimately it will be the therapeutic relationship, I think, that makes it successful or not.
That's good. That's good to hear, because our our journey, okay, the amount of people I spoke to really do say the same thing. It's not geared up for anyone with ADHD.
Right.
So it's, to start off with, you don't know who to speak to in the first place when you think you might have ADHD. There's no real signposting, so you have to
Yeah,
do the research yourself.
of course.
Okay, so if we can't really concentrate and remember what we've read online or whatever like that, it's really hard to then go along with the research and find out. And
Yeah.
then we get an appointment that we have to wait just to speak to someone, in
Mm.
6 months' time, whatever. And it's like, that's, am I going to remember that?
Yeah.
And then you get referred, and then they send you all these sheets with all these questions about your life that you're
Mm.
supposed to remember,
Mm.
you know, and then you have to send it back by a certain time. And if you
Yeah.
miss your appointment or you haven't paid your money by a certain time, you are going to then be thrown off the waiting list, or, you're
Mm.
gonna. It's like
Yeah.
all this to have an assessment
Yeah.
to tell you
Yeah.
if you've got an issue with memory, organization, and you know what I mean. It's just like, what? It's like,
The irony, yeah,
yeah, it's like,
absolutely. Yeah, yeah. No, too right. And I think that's the thing, isn't it? Like ultimately the world is still very much set up for neurodivergent neurotypical people, not neurodivergent people. And our systems are that way, and capacity to alter as well, like I would love to say that with every single one of my patients, I send them, text reminders every week to remind them about their appointment so they don't forget. But, I don't have capacity to do that. So that's an important part of me keeping them at the same time every week, because I'm like, you will then know, Mondays at 3, that's when I see Eliza. Okay. And it's always in the same place. And, because for my own sake as well, I want to be able to remember and not forget, any of my patients. And, but yeah, I think, again, this is the frustration about funding and things like that, is that you could set up systems that were much better equipped to support people, and again, I think we make little adaptations here and there, certainly with some of my ADHD teenagers in the past, like I'll go the extra, I said go the extra mile, I mean this in the sense that I wouldn't normally do it, but I will text them to go, don't forget we have this today, or don't forget this homework, and but yeah, like, I don't think on a bigger scale that can happen unless we have more people to support with
Yeah.
those systems. And but it's needed. I mean, God, it's needed. I could get into a whole rant about EHCPs and all of the different things that are needed, but that will be a
Mm,
conversation for another day.
yes. Yes. An extended conversation. That'd be a
Yes,
very long
yeah,
podcast episode, I think.
absolutely.
Yeah. Okay, so what would you say? What would you advise then for anybody with ADHD or think they've got ADHD,
Mm,
particularly if they're late diagnosed, if they're looking at CBT or other therapies, or kind of like been told about it, but like I don't want CBT, whatever.
mm.
What would you advise? What would you say to
I
those
think,
people?
yeah, to those are, yeah, yeah, I think I'm going to hold in mind that services are not where we want them to be, and that in this day and age, should you want therapy, you might have to be looking at going private. But I think before I even get to that, I'm going to jump to kind of what I said at the start about your hopes and goals for therapy. Rather than trying to cut yourself off to any form of therapy, ask yourself the why. And you might not fully know the why, but I think the why helps in terms of your decision making. So, actually, if the why is, I just want to understand who I am and how I got to be here, and how I'm struggling, something like psychotherapy might fit better, because it allows the space, or counselling, it allows the space for you to wander with your questioning and to really think about things in an open and free way. But if your why and your hopes and your goals are, no, I really have a problem with this specific thing, and again, we're holding in mind mental health, so I'm feeling really depressed. Okay, so again, depression, CBT, the research shows, can be really effective at treating depression. If you are someone with, an ADHD person or an autistic person, my hope would be I could send you to talking therapies for adults, CAMHS obviously for your under 18s, and I'd love to say that you will get, and I really would genuinely love to say that you'll get someone who can adapt, and they are out there. But I think if you're going for free therapy, especially with talking therapies, it's being mindful that they are just like me. They're CBT therapists. They're highly trained, but they will have restrictions on how flexible they can be. They do their 12 to 20 sessions. They're locked in. That's what they can give. Now, absolutely advocate for yourself. You shouldn't have to, but unfortunately, in this day and age, don't we all? So advocate for yourself in the sense of, tell them from the get-go, I have ADHD. I'd really benefit from how, and you'll know yourself better than anyone. I say to my patients all the time, you're the expert on you, so hey, I'm gonna need, could I have a shorter session? Could I have a half an hour session rather than an hour? It's too long for me. Could we mix it up and meet online? Can we do some face to, I think if you can go into talking therapies with that, they might not always be able to accommodate, but at least if you're going off the bat, then you can set that expectation. And then I think CBT again is not the be all and end all. There are plenty of other therapies that I think are worth exploring, especially for people with ADHD. Dialectical behavioural therapy, traditionally used for people with like self-harm, personality disorders, but it's unlike other therapies, it's a skills-based therapy. Is it something are you familiar with DBT? Have you heard of
I,
that
I
therapy
have, yeah, I
before?
have heard of it. I
Yeah,
haven't
yeah,
had it, but I've read up
yeah.
about it.
So I think, DBT, especially for, and I'm holding in mind a few of my patients with ADHD who have ended up having DBT. I think one of the principles of DBT is emotional regulation, helping you cope with distress as well. Distress tolerance and emotional regulation are two of the key pillars of that. So I think, especially if you're ADHD, and again, depending on self-esteem, depending on how you see yourself, being able to have the skills to regulate yourself when you are feeling overwhelmed, when the demand is getting too high, actually CBT might not be right. DBT might be better. So again, if you're coming to me going, I want therapy to help me regulate my emotions more, then I'd be tempted to point you towards DBT. So I'd start with the why, and then kind of go from there. And whilst I'm not going to suggest that ChatGPT should be used at all things all the time, save the planet and all that, I think even just being able to kind of either using ChatGPT or doing that research, like you said, again, you shouldn't have to, but if you do, being able to go, these are the goals I want for therapy. What therapy would you recommend? And then I think going from there, obviously, like you said, if you are in a position you can pay privately and find someone who is either like myself, kind of additionally trained and has more insight and awareness to adaptations, or is neurodivergent, wonderful, perfect. But if you can't, I think you just need to advocate for yourself when you go into the NHS therapies, and just really, and any good therapist worth their salt should ask you when they first meet you, how what do you need from me, how can I help, and again, so training, just making small accommodations, like when patients come into my therapy room, I go, the lights are quite bright, do you want me to turn them off? Or windows open at the moment, would you prefer that to be closed? Oh, we've got these chairs here, but we've got them set up like this. Is there a better way? Just offering those small adaptations can go such a long way.
Yeah,
So yeah, that would be kind of my, again, long answer. I've gone out myself.
no worries. No, that's good. I think one of the issues I think with, I guess, therapy, or how people perceive therapy,
Hmm.
is that, I guess it's maybe it's, I don't know if it's stigma, or they don't give it um enough respect that it deserves. Because a lot of people I've spoken to who, I've had therapy and I didn't like it, so I come away. I'm like, okay, but
Hmm.
if you go to anyway, if you go to your GP and you don't get on with your GP, right? Don't like the advice, don't like them. You didn't gel with them,
Hmm.
whatever. What would you do?
Yeah.
You would change your GP.
Right. Bingo.
Yeah. So
Yeah.
so you need to just change your therapist, not stop
Mm,
therapy altogether. Just change your
absolutely.
therapist.
Yeah, and like the one of the phrases, and it's a very good phrase, but it's used a lot in NHS, is right help at the right time.
Yeah.
And there's so many reasons for that, but I think this is I completely agree, because I think if we rush people into therapy too quickly, let's say they've got other things going on in their lives that needs to be dealt with first, and you rush them into therapy instead because you think therapy is going to fix it all, you're setting them up to fail, and you're potentially ruining their future self having meaningful therapy. And in the same way that it frustrates me when I hear people say, oh, I had CBT and it was crap, and then I go, okay, well, what CBT did you have? Oh, well, I met with some person for 3 sessions and they did a bit of CBT, and I'm like, that's not high intensity CBT. You did not. Yeah. And it's important to have that, to be able to differentiate the difference. And so yeah, right help, right time, with the right person, with the right therapist as
Yeah.
well. Um, we talk about it a lot in therapy when we're thinking about whether someone should receive therapy. We talk about like Maslow's hierarchy of needs, that whole idea of, that there are layers to what people need in order to get the best and most from therapy. If a child, obviously for me, if a child is in foster care because they've had a really horrific childhood, and now they're in foster care and the foster placement is falling apart, me coming and going, want some therapy? It's the wrong time. Like,
Yeah.
they need to feel safe. They need to feel loved and secure. If their education is falling apart, again, not necessarily that's the reason to not have therapy, but we have to be mindful that if they're not in education, then they're missing out. Like, there's some other needs that are there, and then therapy is the complementing thing at the top. And I think often people flip it the other way and they go, that person's life is falling apart, send them to therapy, and then that has the potential to ruin, yeah, the future therapy that they would probably benefit from if they had the chance to have it at the right time
Yeah.
with the right person.
I mean, when I started therapy the first time, that's before the diagnosis, before I really knew anything, and
Mm,
I just wasn't coping with everything.
mm,
And I went to see a psychologist, and I was 6 months, 8 months maybe, and that was great because we talked, and I really needed to talk,
yeah, yeah.
and that was great. But when I also got diagnosed and all that, and okay, so now the questions I have now, she's not the best person for me.
Mm,
She
mm,
was then. I
yes.
absolutely appreciate everything that we went through
Mm,
then, but now I've I've chosen someone different for a different
yeah.
reason, um, and again that has works well for me.
Yeah,
So
yeah. And I think that's, again, as promised, this isn't an advertisement for psychotherapy, but as you mentioned it, I think, what psychotherapy does, for those who are listening that maybe don't know, is psychotherapy helps you kind of go into the what I kind of call the unseen, the unfelt, but it's there. It helps you kind of tap into feelings that you might have experienced and you don't have the words for those experiences. The pre-verbal, non-verbal, early childhood experiences, and psychotherapy is so helpful, certainly for, in our services for young people who are in foster care or have been adopted, who have had these they know that bad things have happened to them, but yet can't quite tap into what it was, but yet are left. The body keeps the score and all that, the things that we feel. So it's why picking the right therapy for the right time, because, like you said, psychologists, to be able to just have the space to talk, fantastic, but that wouldn't have been as productive if and the tendency is to stick with what we know, but sometimes it's it's a mix. I mean, I'm fortunate enough to be training in EMDR, which is a fantastic form of trauma therapy, and I'm training in it, one, because I think it's like one of the best therapies. I'm very biased, but I do really think it's one of the best therapies. But two, because I recognise CBT can't meet all needs all the time, and I wanted to add another string to my bow, so that even though CBT does treat trauma and PTSD, EMDR treats it in a completely different way. And especially for neurodivergent people, what I'm finding is, for trauma, for single event trauma, CBT can be really helpful if you want to talk about it. Because actually, some people, it's a really cathartic thing. I want to talk about this thing that happened to me and I want to go into the details. Great, CBT for trauma, perfect. But if you don't, or it's complex trauma, then actually EMDR is great, because we're not asking you to talk out loud. We're just asking you to think about it as we help you process it. Really powerful. So again, I think, yeah, it's annoying that you have to be burdened with the responsibility of doing the research yourself, but I think it's important when you're thinking about therapy to do some of that research and to really think, not rush into therapy, not rush into counselling. Really sit and ask yourself, what do I need? Because they're going to ask you anyway when you go. So you might as well start doing that question. You might as well start that process now and think about it before you kind of make any arrangements.
that's brilliant. Um, Thank you. Thank you so much for coming on and talking with me.
Yeah, no
It's
worries.
been enlightening, it's been educational, um, and it's a conversation that we need to have because people need to be educated about what is going on because,
Mm,
like everything else in our world, we're not told anything, you know.
yeah, right.
So it's nice for these conversations to happen,
Mm,
for people to understand what to expect when they go to a therapist, or I've had a
mm,
GP on. It's just to actually know the factual aspects of things,
mm.
rather than just guessing what things are and getting it wrong.
Yeah,
We need to
yeah,
know
absolutely.
what is going on.
Mm.
But like I say, thank you. I'm waffling on now, so I'll try and contain
I do that
myself.
too.
It's, it's,
No worries.
It's one of those really weird things where if you're going to explain anything to me, please just one liner. Otherwise, I'm
Yeah.
not going to remember.
Right.
If I'm going to explain something to
Yeah.
you, I'm going to give
Watch me
you.
go.
Yeah.
Yeah. War and peace. It's happening. No,
Yes,
not the same.
absolutely, absolutely.
Oh. But thank you for having me on. I appreciate it. It's
No.
always nice to come on and fly the flag of therapy and also thinking about it from the perspective of neurodivergency. So yeah, no, thank you. Appreciate that.
It's been great. Now, you mentioned about TikTok. Can people find you on TikTok? Can they follow you? You okay with that?
They can, absolutely. Yep. So EJ Talks. I'm on TikTok, and yeah, I just offer all kind of advice and answers and questions and spaces to think about things to do with CAMHS and therapy, and yeah, just welcome to follow and ask me questions.
I think people should do that. I follow and I watch the clips, and they are really informative, really easy to listen to as well, which is important. So yeah, really good. But I'll put the link on the podcast and everything.
Brilliant. Thank you.
Okay, so thank you again for coming on. As always, guys, for you guys listening, be good, be kind, and remember, you're not alone. Thank you. How do I... Where's my thing gone?
I think that's how you should end the podcast.
Where's my...
Feel like, how do you...